Good evening or good afternoon, everybody. Thank you for joining us for tonight's or today's New Voices session on Empowered Care, a wound ostomy and continence nurse's guide to caring for individuals with spina bifida. My name is Juanita Panliner. I'm the Spina Bifida Association's National Resource Center Manager, and I'm joined by my colleague Stephanie Myers. Very happy to introduce Ferne Elsass, which is the Clinical Resource Specialist with Smith Nephew. Ferne has over 26 years of experience in pediatric nursing, and her clinical background includes a lot of work in neonatal and pediatric intensive care, as well as trauma education. For the past 3 years, she has been the clinical resource specialist with Smith Nephew. She's focused on advanced wound care, and ostomy care. And so I will let Ferne explain more about what she does and what she knows, and we're really excited to get her expertise. And so with that, I would like to turn the session over to Ferne.
Thank you. Thank you so much. I'm so excited to be here. I have been looking forward to this presentation for a really long time. I get to talk about the things that I love, which are my patients and my past experiences, as well as wound care and how we can better provide wound care for our patients and our loved ones. So a little bit about me. I do work for Smith Nephew. I am a clinical resource specialist. So we are not going to talk about products specifically. If offline you want to talk about different things that you're using, I will be more than happy to discuss those with you. But for tonight, we're talking about spina bifida and the care of those patients. I'm also going to take myself off camera so we can really concentrate on the presentation. So my history, I took care of spina bifida patients. We're going to talk a little bit about the prevalence. We're going to talk about what types of skin breakdown they may have. What are those common vulnerable areas that those folks suffer from or suffer with? We're going to talk about the phases of wound healing and what a wound looks like as it starts to heal. What are the red flags that you need to identify when a wound isn't healing very well? And how do we conduct basic skin inspections to make sure we know what interventions are necessary? What type of wound strategies are going to work best to help us with prevention of pressure injuries? What type of things do we need to look for surgical site complications or chronic wounds, especially with those that have spina bifida? And hopefully we can create a caregiver plan to improve the quality of life of those that are living with spina bifida. Now, when I first started with nursing, I only knew that spina bifida was a little patch of hair that might show up on the back of a baby right above their bottom, and that's what I needed to look for, and that's really all there was. And it took me a long time of caring for patients and meeting patients with spina bifida to understand that there was more to it than that, and that there was more that could develop. And so what spina bifida is, it's a neural tube defect. The neural tube is that tubing that will eventually form the brain and spinal cord, and it either doesn't fully fit into that spinal cord or it's going to start to bulge out. And honestly, I was probably precepting other nurses before I even knew that there were other types of neural tube defects. Now, most common is going to be a closed defect, but like I said, this is what I knew to be true, that there was going to be some sort of bulge or area of hair growth that was on the back of the baby's bottom, and that's how we knew that this particular child had spina bifida. And this is the most common neural tube defect. Only 1 in about every 1,000 babies do have it. The occulta is going to be the more common, but the aperta, which is the outer where it is bulging outside of the skin, is going to be more serious. Now, having said that, that doesn't mean that complications aren't going to exist for both. But when you look at the differences, you can see how one might be more severe. That if you have this bulging, that you're going to have maybe more need for surgery, may need for different outcomes. And so that severity could cause different things in the future. Now, the neural tube forms at about the 7th to 30th day of fetal development. So this is before most women even think about being pregnant. And they were able to link a folic acid deficiency somewhere in the late to early 70s, and they started adding those vitamins to food. Now, although there are some maternal risk factors like obesity, diabetes, there's really nothing that we can say this is the one thing, and it is really multifactorial. So just like caring for those that have spina bifida, it's going to be multifaceted. It's not going to be a one size fits all. It's really going to have to do with what that particular person needs and what level of care they need. So when you look at management of spina bifida is going to, in some cases, start with surgery. There may or may not be mobility issues. And even if I look in my past life, when I was, a baby nurse coming up, I thought that all spina bifida patients weren't able to walk, that they were all wheelchair bound, and that there wasn't going to be any ability to do that. And that is really not true. But there are still some mobility issues that have to be focused on. There's things that they may need to help them walk, to help them function every day. And those may be things that we need to take into consideration. There's going to be both bowel and bladder care in some cases, maybe one versus the other. And there's going to be devices that are going to be necessary in order to make sure that we have that high quality of life that everyone should expect. Now, what's a wound and ostomy nurse? So the simplest explanation is we are a clinical partner that looks and assesses wounds, assesses ostomies, and then helps to define what treatment pathways are the best in order to help that particular person. We help to individualize care for any patient or person that we're working with. We have certifications. We are board certified. I myself have 3. I am certified in wound and ostomy care, and I'm also certified in pediatrics. And this is just a higher level of education. We have to be certified by the board. Every 5 years, I have to recertify to make sure that I still have a functional knowledge of wound and ostomy care. But our goal is always to seek out the cause. We want to figure out what happened to cause that wound, because once you figure out what caused it, the pathway to prevention is much simpler. And I would say, if not all wound and ostomy nurses have a passion for prevention. We don't want to see wounds happen. We don't want to have to fix them. We want that person to have the best quality of life possible. And the best way to do that is to prevent as many wounds as possible. But we are a functional member of the interdisciplinary team. And it has always been my belief that you have to work as a team to give the best care to the patients. Now, the complications that can arise with those that have spina bifida can happen with surgery. Most often, they're going to have one, if not several different surgical procedures, which in some cases can lead to infections. Now, we're going to focus a lot on pressure injuries, but I don't want to stray too far away from surgical, because those complications can include infection. And whether it's a pressure injury or a surgical injury, you can develop infection. Now, surgical wounds really should be as simple as a cut is made, it is sewn back together, that area heals. In about 3 to 7 days, you start to see that healing edge, and that surgery really is behind that person as they rehabilitate. When infection starts to develop, that may not be the case. There's also going to be complications with mobility, whether it's use of a wheelchair, whether it's use of braces or AFOs that are going to help to prevent any further injury or deformity as things start to heal. There can be complications with independence, whether that's a child is too young to be independent and they require the assistance of their parents, or a teenager who wants to feel independent but doesn't want to feel like they can't do the same things as other kids can. It's making sure that we're allowing for those who are independent to be as independent as possible, and find ways to structure that independence so that, again, we're all living with that high quality of life. There's also a lot of caregiver strain, and in the areas of a parent or even a spouse, there's that feeling as, well, this is what I do because I am this child's mother, or that I am this child's father. But we are still caregivers, and we still can feel that strain and the stress if we don't take care of ourselves. There can be multiple complications with bowel, bladder, and even possibly, if an ostomy is placed, the care of that ostomy. So I'm not going to focus a lot on ostomy care, but I do want you to feel very free to ask those questions if they come up. So when we look at wound healing, the first thing we have to think about is when that wound initially happens. And at first, that wound is going to go into hemostasis. We need to get that controlled bleeding. We need to stop that wound kind of in its tracks. And that takes about 1 to 2 days. We usually maybe put an ointment on something, we cover it with a Band-Aid, but we've kind of got it under control for those first days. And that happens within minutes to days. And then we move on to inflammation, which can happen relatively quickly. But that's when the wound is starting to clean itself. So we've got those white blood cells, those neutrophils, everything's coming into the wound, it's cleaning it up. And this lasts about 10 days before we move on to the next cycle. And that's going to be proliferation. Once we get into proliferation, we start to see new tissue growth. This is when those extracellular matrices come into play. We have collagen that's coming in and it's rebuilding that tissue. And this can take several weeks, if not months, to progress. Next, we're moving into remodeling. Now, the remodeling stage can take up to 2 years to finally complete. So this is that strengthening phase. This is where the wound is going to get back to its normal self. The problem is with some of our larger wounds, we're only hopeful to get to about 75% of as good as it was prior to that wound happening in the first place. So when you're thinking about pressure injuries can happen very, very quickly. It can happen within a matter of 20 minutes. We can develop a pressure injury. And that strengthening phase, that healing phase, can take upwards of 2 years before we can have a fully strengthened and fully healed wound. So when we're looking for infection, we want to really concentrate on where that bacteria, what that bacteria is doing in the wound. Initially, you're going to have this contamination phase. Now, all wounds are dirty. There is no such thing as a clean wound. No wound is sterile. You are going to have bacteria present. We have bacteria on our hands all the time. Some of them actually help to protect us. We have yeast on our skin at all times. So that bacteria is not a threat to us. It's contaminated, but it's not replicating. Then we move on to colonization. These bacteria are starting to replicate, they're starting to grow, but not really causing any harm to the wound. This is the time where we really have to be vigilant to make sure that we're preventing infection when we can. You're not going to often use antibiotics, whether topical or otherwise, in these stages because that can actually hinder the body's active ability to fight off this bacteria. And we want to make sure that we are allowing the body to do its natural course. Once we start getting into biofilm, that's going to be a localized infection. Now, biofilm is kind of a sticky substance that gets on the wounds, and the bacteria just love to get into it and grow, and they really find kind of their happy space there in that biofilm. This is going to lead to spreading of infection. That biofilm is very difficult to clean off. It's very difficult to get rid of. At this point, we're probably looking at using some sort of oral antibiotics or something else to really help, while also using something on the outer aspects of that wound to prevent bacteria. The infection will then start to spread, spreading into deeper tissues, our muscles, our organs, other body cavities, until it moves into sepsis, which is full body sepsis and can really affect the whole body. The goal is to always maintain vigilance in the earlier stages to make sure that we're not allowing for that bacteria to get in. We're making sure wounds are clean. We're making sure that wounds are covered. They don't need air. A lot of times, that's what grandma told us. We got to let it open. We got to leave it open to breathe. Wounds are going to be protected when they're covered. So it's always a good idea to keep those wounds covered. Maybe allow for a little air to get on there so we're not allowing for a lot of maceration, but overall wounds should stay covered so that they don't continue to get contaminated. So those initial signs of infection are very, very common. It's going to feel warm to the touch. It's going to have some swelling. You may see some pus or purulent drainage coming from it. There may be some pain that's going to be associated with this wound, and you may experience an odor. And most of the times, the odor, we have to clean the wound before we assess for odor. We don't want to, because all wounds are going to stink to some degree. So we want to make sure that's clean. Once that starts to spread, this wound isn't closing. This wound has that increasing erythema. It's starting to feel more pain. It may also start to have more breakdown. And if you look around the edges of that wound, when wounds drain, it causes that maceration around the skin, causing a lot of redness, a lot of discomfort around the wound, not just the wound itself. Folks may lose their appetite, and again, may lead to sepsis and organ dysfunction. Infection is going to cause delayed wound healing. And most of the time, the reason that wounds don't heal is they get stuck in that inflammation phase, typically related to infection. But one thing with our spina bifida patients and our family members is that they may have decreased sensation and they may take a little bit longer to heal for no other reason than that is how their body is designed. It doesn't have that sensation. It doesn't have the same type of circulation. They may not have that ability to move around quite as much, and that may lead to further issues with wound healing. But whenever you have that deeper infection, you'll have that delayed wound healing. You'll see something called hypergranulation, which is where the tissue kind of overgrows. It looks really beefy red. It's very friable and it will bleed very, very easily. These wounds also tend to have a lot of drainage. That drainage will actually cause further breakdown because it'll break down the skin around the wound, causing the wounds to get larger, more pain, and certainly that malodorous, that smell that where you kind of like, this wound smells funny. Now let's talk specifically about pressure injuries. There can sometimes be some difficult, well, how do we figure out exactly what caused it? Well, with pressure injuries, it's very, very specific because it's a localized area of damage that is over a bony prominence or under a medical device. So you have to have those things in line in order for it to be considered a pressure injury. They can be open or intact. They can also be in combination with shear, which is a drag across a surface. And it also has a lot to do with each individual's tissue tolerance. Just like each of us have a different fingerprint, every human has a different tissue tolerance. So you could have one person that could sit in a position for 8 hours, never develop a pressure injury, and another person that's sitting right next to them sits for 20 minutes and develops a pressure injury. There's no way for us to completely individualize care. So we do have to really paint with a broad brush to make sure that we're making sure we're taking care of all of the different things that could prevent pressure injuries. So the reason those develops is you've got the bone pressing against the surface. You've got the surface pressing against the bone. And that soft tissue just doesn't get good blood flow. And that causes those wounds to develop. Now, that's related to the direct effect. You also have that inflammatory response. So the body is trying to overcome these issues, but it leads to ischemic damage because it just doesn't have good blood flow across those surfaces. Friction is going to be two surfaces rubbing against each other. Shear is going to be the drag. Whenever you put any of those three things into combination, you have the likelihood of developing a pressure injury. It just puts that particular area at risk for developing that injury. So that pressure clamps down on that blood vessel and it causes that ischemic injury. So there's just not good blood flow. So you can imagine when you are sitting in a particular space for a long period of time, your bottom gets uncomfortable, so you start to shift in your seat. If someone isn't feeling that pressure, if someone isn't feeling that particular discomfort, they're not going to move. They're going to stay in that position that feels comfortable to them. But that pressure can lead to destruction at layers underneath the skin that we can't see, causing damage to the muscle, as well as the skin and the fat above. Now, these are some pressure points that you'll see in surgical procedures. And because our spina bifida population are going to have multiple procedures, it's important to know what types of positions they might be in. Also, if they've ever had a pressure injury in the past, they are likely to develop a pressure injury in the future. To me, it is a precursor. If you see one, you will see another one. And it basically has given you that red flag. Okay, I am a person who is prone to develop pressure injuries. I need to make sure that if I'm going into surgery, that I'm protecting those areas that could lead to injury. So depending on the position that that patient or person is in, you would want to cover those areas. Now, most ORs are very good about making sure that those positions are taken care of. But the areas that are going to be at most high risk are going to be the areas under the most pressure. So if you look at the supine position in that top area, that's showing you if a patient is laying down, all of the areas that are going to be at risk for developing a pressure ulcer. In the seated position, it puts those hips, that ischium, in much more danger. Lateral positions, supine positions, prone positions, we're all looking at areas where the feet and ankles could be disrupted. Our spina bifida patients may already have issues with those areas because they wear braces or they've had serial casting, and that could then lead to further injuries. So just always a good idea, if you know the position, just to make sure that those are padded, whether your family member or yourself, if you're going in, to just say, this is how I'm going to advocate for myself. I'm going to make sure that I have those pressure injury prevention devices in place. So sitting is a dynamic position, and we should be kind of moving. Recumbent position is static, where they're pulling down in the bed. Now, 75% of that weight that when we sit is going to be sitting right on top of our hip bones. It's going to be sitting on there. You're going to feel it in your buttocks. You're going to feel it in your sacrum and possibly even in your coccyx. So I know I can't see everybody, but I want you just to take a minute to kind of think about where your body is positioned if you're sitting. And what happens when you just lean to one side? That's going to lift that pressure off of that area. And then if you lean to the other, you can feel that hip coming off. If not, this is still going to decrease the likelihood that you will have a pressure injury. So it's always a good idea to make sure if you're in a chair that you're shifting that bottom, especially if you have any risk of decreased sensation or no sensation. You want to make sure you're shifting, crossing your legs if you can, leaning to one side, having a pillow in your lap that you can lean into. Those that are unable to change positions are always going to have a higher incidence of pressure injuries. So we have to keep in mind movement, even reminding our loved one, hey, let's take a shift in the chair, to make sure we limit how much time they're spending in one position. So when we talk about the classifications, I really would like more focus to be on the levels of tissue damage versus the numbering, but we only use this classification system for pressure injuries. It describes the level of pressure injury or the tissue destruction, and we're only really talking about the tissue we can see. We're not trying to talk about tissue that we can't see underneath. We don't guess. We like to know exactly what stage this is without trying to reverse. So to be specific, a 1 can become a 2, can become a 3, can become a 4, but a 4 can never go back in time and become a 1. So we don't ever reverse our stages. Now, stage 1 is going to be a superficial injury. Now, whenever you're doing let me just backtrack just a little. Whenever you're doing a skin assessment, pick kind of the same time every day, every morning, every night. I'm going to do a full head to toe look at my skin as much as I can. If you can't see it and you have a loved one that can look it over, have them do it. If not, get a mirror, make sure that you're looking at as much skin as you can. And you want it to be uniform in color, uniform in texture. You don't want to feel any weird boggy spots. Caucasian skin is going to be much easier to see pressure injuries on than darkly pigmented skin. The darker the color of the skin, the harder it will be to see pressure injuries. But so you have to be more vigilant anytime we're looking at darkly pigmented skin. If it feels weird, we have to check for the temperature. We have to check for the texture. It's going to be even more important to make sure all the lights are on and we're really making that effort. So the stage 1 is going to be a superficial area on the skin. It will always be intact. It will be a local area of redness, pink, just has kind of a red hue to it. We consider it non-blanching erythema. So you push on it, the color doesn't go away. But if you push on it and the color does go away, that's considered blanchable. I have seen many injuries that were blanchable and still became a much worse injury. So I would say if you have a red spot on an area of a bony prominence that has been under pressure, treat it as if it's going to become a pressure injury. Better to be safe than sorry in those instances. So here are a couple of real life pictures. Again, kind of that superficial redness. I press on it, the color doesn't really go away. Not a lot of pain is going to be involved in these injuries, but what you have is a red flag that's telling you that you have the likelihood of developing a really significant injury in this area and the possibility of developing another one in the future. So take these very seriously, but ultimately, we take the pressure off, they go away, maybe a pressure relief dressing in the future to make sure that this area isn't under constant pressure. But this is an area worth watching. Stage 2 is a partial thickness injury. So this means we've exposed the dermis or we have a fluid-filled clear blister. These can be painful because now we're starting to dip into the nerve endings under the skin. They may be some drainage if they're open, and these can easily be confused with other types of injuries. And when I get to the picture, you'll see why. So if you look at the picture to the lower left of the screen, this is a pressure injury, but there's also some diaper dermatitis around it. So it can be very, very difficult in some cases to say, is this pressure or is this incontinence? Especially if you're in an area of incontinence. But that would be one of the things that we would look for. Is this particular person incontinent? Is this only to one side or both sides? If you're seeing it on one side, it typically means it's pressure. If you're seeing it throughout, it's diffuse, then it's usually incontinence. These areas are really that top layer of skin. In that larger picture around the ear, you can see a combination of both a fluid-filled blister and an open area. I would encourage you to keep blisters intact for as long as possible because this really creates a biological band-aid that will prevent infection. Once infection starts to get in, then we've got a new problem. Usually over joints, or if the area is really painful, we'll recommend de-roofing the blister, but this really should be done under medical care. It shouldn't be done in your bathroom with a pair of Q-tips. A stage 3 is a full thickness injury, and this is just going to start to dip into the adipose tissue. There may also be a epibole, which is a healed area around the wound, and this usually happens when wounds are around for a really long time. The outside starts to heal before the inside. These wounds may have slough or eschar, and slough is a yellow fibrinous substance that is dead tissue, and eschar is its darker, thicker, more leathery neighbor. May have a little bit of that, but you want to be completely 75% of that will be removed before you determine that it's a stage 3. The depth is going to vary, but we're not looking at muscle and we're not looking at bone with these wounds. There may be some undermining, which is a tunneling, is kind of a shelf under the wound, or tunneling, which occurs when you've got true depth where you could put a Q-tip or even a finger into some of these wounds. So here are some instances of stage 3. The one at the very top is on the back of a heel. It's nice beefy red. It looks like it's probably going to heal very, very well. When you look at the one beneath it, you can see that the tissue isn't quite as vibrant. This is likely a delayed wound, and that healed wound edge is showing you that there's a little epibole there. Now, in the larger wound, you can see a combination of a stage 3 as well as a stage 2, and that is a device-related injury, which we'll talk in a little bit more detail. But you can see where that's got that yellow fibrinous tissue in there. That would be a little bit of slough that's in that wound. With some of the wounds, especially in the genital area, if you can get away with using a cream, that can sometimes help because they can be just very difficult to dress. And if a person is incontinent of urine or stool, it can really exacerbate and make those wounds much worse. A stage 4 wound is going to be full thickness. At this point, we're seeing muscle, tendon, ligament, cartilage, bone. We're seeing all the way down to the core of the body. There may or may not be visible slough. Again, it's just going to be dependent on how much of that dead tissue has been removed. And there may be some undermining or tunneling. Most often, these wounds really progress because of infection. And because once they get to a point where they start to get infected, they just continue to get worse. But again, we're not going to go back in time. Once a 4, always a 4. These wounds have, you can see a little bit of tendon, a little bit of bone kind of at the bottom of both of these. In one, we've got a much more vibrant wound where we've got a lot more beefy red tissue. And the other one, it's a little less vibrant, but both of these are long-term chronic ulcers. You can tell that by the epibole that's around the edges. An unstageable pressure injury is also full thickness, but we have no idea how to stage it because there is so much slough and eschar over the wound that we just can't see the bottom and we just don't know how bad it's going to be. And what can happen in these cases is it can become a 3, but then also progress to a 4 because it just is going to get worse before it gets better. Anytime we have stable eschar, we want to leave that in place, especially if it's around a heel. We can do a lot more damage than good if we start removing eschar that's nice and dry and stable. Again, working like that biological Band-Aid. And here's a really good example in this heel. This eschar, thick, leathery. We don't know if this is a 3 or a 4, but more than likely a 3 because again, this is a full thickness injury. We'd have to debride that to be fully certain, but we can do a lot of damage to that heel. So we are going to more than likely wait that out and keep that as dry as possible. In the second picture, this is a device-related unstageable injury. And you can see that eschar, that all has to be debrided away, either by sharp debridement or enzymatic debridement, possibly autolytic, but it has to be removed before we can stage it. The deep tissue injury is sort of the mystery of injuries because even though it's a full thickness injury, and the skin is typically intact or it'll be a blood fluid blister, these can sometimes just go away on their own. And they will often be mistaken for bruises. This is not a bruise. This is an area that's under pressure, but it will have this deep maroon purple discoloration. There may be some epidermal separation. We have this blood blister that's formed in that area. And you will see pain and temperature changes before that purple color identifies itself. And this is why, again, that when we have a darker pigmented individual, we need to be really assessing, palpating, making sure that we're checking for any of those changes. But these can resolve just as quickly as they came. So first thing we're going to do, make sure we get that pressure off and allow that pressure to be removed, and it can sometimes go away on its own. What tends to happen is they become unstageable, and then we go through, is it a 3, is it a 4, and then we treat it dependent on how it evolves. So here are some really good pictures of what deep tissue injuries look like. Again, this deep purple color, much different than that pink red color that we had initially with the stage 1. Very, very deep, really identifying the amount of injury. Now, this is just something that I got really, really good at, unfortunately, with deep tissue injuries. But if you look at this one in the first picture is much more likely to go away on its own. This is something that's fading, where if you look at the second picture, you can really see that red color around it, as well as that deep, deep purple, almost looking black. This wound is going to be around for a while and more likely to worsen before it gets better. Device-related injuries are always related to a device. We identify them based on whatever stage they appear to be, but there's always a device that it's underneath. These are always for medical purposes. We have to have them. In some cases, they are braces, they are AFOs, they are the person's wheelchair. This is how they get around, but they've leaned in a certain position and it led to an injury. But the wound will take on the shape of the device. Now, related devices can be any device. My rule of thumb is if they were not born with it, then it is at risk to them to develop a pressure injury. Number one, most common of anything is going to be oxygen delivery equipment. Now, not a lot of folks with spina bifida have oxygen delivery equipment like nasal cannulas, masks. They might have trachs. But for the most part, oxygen delivery equipment is not going to be the greatest risks. It's going to be the braces, the splints, the casts, because that limb may put pressure against that cast or splint, causing that injury. And this is a must do. This isn't something that we can negotiate. This is something that we have to do in order to provide functional support, functional movement, that ability to have mobility. And then, of course, those the wheelchairs that some of our patients or loved ones may have, because that is their way to get around and see the world. Mucous membrane injuries are always going to occur inside the mouth or inside the nose. These cannot be staged because of the type of tissue, and they usually occur uh, because there's a tube or something in the mouth or nose. This would be something I would be more aware of if patients are in the hospital, as they would have devices that might be in their mouth or nose. So this is a chart that will be available to you that you can have, that is a really great way to identify those stages and give you a functional way to look at them. So this is the way I taught students. You look at an apple and it gives you a really great indication of where what type of pressure injury that is. Stage 1, just going to be a pink discoloration. Stage 2, we've peeled the skin. In the stage 3, we've taken a bite, so we've got a much deeper wound, deeper into the skin. At the stage 4, we've hit the core. This is the deepest wound we're going to have. Our deep tissue, again, is bruised, but that's a bruised apple, where we know that that is not a bruise like a traumatic bruise that can occur. This is a bruise this is a purple discoloration related to pressure. And the unstageable would be our toffee-related apple. It also has a little bit of information on incontinence-associated dermatitis, which can really affect our incontinent patients, and just some things that we can do to prevent that. So the biggest wound care considerations is, where is the lesion? Where has it occurred in the body? Because that particular neural tube lesion can determine how much sensation, or where the sensation is, and how much they may be able to feel, and how serious the injuries may be if they develop pressure injuries or surgical site infections. They are going to, in most cases, have a wheelchair use. When wheelchairs are in use, it puts the sits bones, it puts the hips, it puts the sacrum all at risk for developing pressure injuries. And again, you may have one person who has a wheelchair their entire life, never develops a pressure injury, somebody who has it for a week and develops 2. So it's always something to keep in mind. When folks are incontinent of urine or stool is going to be worse for the skin, but that moisture on the skin is going to soften it and make it ready to develop pressure injuries. So anytime we can use very absorbent briefs if we need to, or have an incontinent plan, bowel and bladder plans, always a really good idea. If they've had any kind of shunt placed, it will put them at a higher risk, or any below the knee orthopedic surgeries put folks at a greater risk. Also, male gender can put patients at a greater risk. Best way to prevent is there sensation? If there is not sensation, then we have to be conscious of when we move and how we move. Wounds are also going to take longer anytime there is sensation absent. So other comorbidities that can really cause issues are smoking and diabetes. Having those things managed or under control can really help with preventing wounds and helping wounds to heal better and faster. Always making sure we've got some sort of repositioning plan in place. It's not always going to be perfect, but allowing for a minimum of 15 minutes off of a surface and get those bones, allowing that skin to recirculate, can really do a lot for preventing pressure injuries. Making sure skin is clean and dry, but not overly dry. We don't want to be pulling off socks and dust flying out. We want to make sure that our skin is well moisturized. So clean, dry, well moisturized. If there are issues with incontinence, I would recommend a barrier cream with zinc. This will really help to waterproof those areas, help smaller wounds to heal, especially if there's any type of incontinent related issues. There are a few more creams that can be a little bit more protective. Those are things you can usually get from your physicians. If there are any physical or cognitive barriers, we have to be aware of those, to make sure that if we have someone who doesn't understand, that we find a way to make sure that we're still taking care of those things. I was when I was a nurse at the bedside, it was always very important with me to follow up with family members, parents, anyone that could tell me, what does pain sound like? What does pain look like in your child? This is something that's really, really important for caregivers to pay attention to, as well as to be told, because pain can look different if there is a cognitive or physical barrier. And then I cannot stress this enough, assess the skin. Have something that is muscle memory. We do it every day at this time, before my bath, after my bath. We're looking at the skin head to toe, checking with a mirror. If it's a younger child, teaching them how to do it so they're doing it as they get older, that this is something that feels wrong not to do, to make sure we're always looking at that skin.
Okay.
So this is
Hey,
an
Brock,
interview.
thank you so much.
Oh, let me pause it. This is an interview that I did with a friend of mine. His name is Brock Masters. He actually works for one of the ostomy companies. He is a person living with spina bifida. He is also an ostomate. And I have had the chance to get to know him a lot more, and he agreed to do this interview. So I'm just going to play it and sit back and listen with you.
Okay. Hey, Brock, thank you so much for joining me this morning. I'm really excited to talk to you about spina bifida and those that have spina bifida. First of all, thank you so much for talking with me.
Yeah, my pleasure.
For those of you that don't know Brock Masters, he is a person that I met through his wife, Andrea. We met at conference, and she spoke of him having spina bifida, him having an ostomy, and I started following him on LinkedIn and was really impressed by his story. And I thought that this would be a really great opportunity for him to share his story, raise some awareness, and get an opportunity to help others who have spina bifida and who may have ostomies as well. So thank you, Brock, for being here. Why don't you go ahead and kind of introduce yourself and tell us a little about your life so far.
Yeah, so good morning, everybody. Good afternoon. I'm Brock Masters. I live just outside of Chicago with my wife, Andrea. We've been in the United States now for about 13 years, born and raised in Ottawa, Ontario, Canada. My situation slightly different. I wasn't actually diagnosed with spina bifida until the age of 10. And so I had a number of challenges growing up with bowel control, essentially. And so, having bowel accidents, having to go through the emotional challenges of knowing that this was not on purpose, and having to kind of pull through that. And so I hit puberty very young. And from what I'm told, individuals with spina bifida typically hit puberty at a younger age. And so at the age of 10 is when I started going through puberty, and I started having pain in my back and my feet started turning inwards. And so we went to go see a neurologist, and very quickly he had identified that, in fact, this looked like spina bifida, and that he was going to essentially get me in for an MRI just to ensure that it was proved out that this was in fact the case. So I guess from there, I went through a battery of operations in my preteen and then early teen years, just to help kind of deal with what was manifesting in terms of physical deformities and some of the challenges I was facing.
And that was one of the things that surprised me most about your story, because it had been my experience that it was diagnosed in infancy, and it was something that was diagnosed right away. So I was very surprised. So it was exciting for me to learn something new about that. Was there any time where you really felt that you were misunderstood or unsupported in what was going on with your journey?
Yeah, I think certainly in my particular case, having had these challenges with my bowels, and trying to explain to my parents in the moment that, like, look, this is not on purpose. This is something that's happening. I have no control over this. That was very difficult in terms of feeling misunderstood. And then, as I went through surgery, I think high school was kind of interesting, funny, however you want to view it. Just because I was having so much surgery one day I'm walking, one day I'm in a wheelchair, one day I have crutches. And there was just a lot of like misunderstanding of the current situation at hand. But those who were really close to me understood that I was going through this. And so I was very fortunate that I had really good support through a friendship network of folks who would come visit me in the hospital, understood what was going on. And then a little bit later in life, when I became comfortable, sharing with friends that I had to use catheters and had a cecostomy at the time prior to having a colostomy. Just good friends who were willing to like shove things in their pockets for me when we were out and about. So.
Yeah, that was one of my favorite parts of your story. I have had a very fortunate experience that most of the kids that I have worked with have had very, very supportive friends, very supportive families. I know that it can be very, very challenging when you really don't know what you're supposed to do or what you're supposed to say. So what kinds of things can you tell caregivers, loved ones, patient care providers that can really help those patients that they see, those family members that they see, to live more independently and feel a little more in control?
Yeah, that's a great question, Ferne. I think everybody has a different level of personal independence. And so, the best balance happens when caregivers respect a person's abilities and really listen first, ask what they want help with, and, try to give them the opportunity to try something themselves first, even if it takes a little bit longer. Offer support, but don't assume that someone's incapable of executing. It may take a couple tries. And then encourage problem solving and giving people space to figure out what builds confidence and independence. And I think intermittent catheterization is a great example. I've worked with a number of parents who may feel that their child is either too young to take this on by themselves, or they've been doing it so long it's kind of hard to step away from that support. Certainly, young boys and hygiene are not always the strongest together. And so, how do you as a parent, for example, help that child learn the steps of intermittent catheterization to the point where they can become independent? And so I've always, when working with parents, and I coach wheelchair racing, so we have a number of kids who have spina bifida on the team, and I always discuss what I call kind of the bookend method. Like, let's get the child really adapted at proper hygiene. Let's build that foundation of understanding why it's so important. So we're doing hand washing and cleaning the meatus and taking good care to make sure that the catheter stays sterile. Mom or dad do the intermittent catheterization. They do the removal. Once we've mastered the hygiene piece, let's now practice the removal of the catheter and the disposal of the used product. And so once we've mastered sort of the front and the back end, now they can take on that intermittent catheterization on their own, driving towards independence. And so certainly not everyone, depending on, again, their either physical or cognitive abilities, may be able to master all of it. But I think feeling included in a process, if you can't do everything yourself, is still very important in terms of your personal self-worth and feeling like you've taken on ownership over this.
When you look back, and I think you can also kind of compare that to the kids that you're looking after now at the wheelchair races, were there activities that you could do without independence? And when did you know that you needed help? Was there a way that you appreciated the help, or when was it that caregivers can offer help to be supportive but still provide that independence?
Yeah, and I think the opportunity to ask good questions and highlight that support is there. I think depending on the age of the individual, there may need to be the decision like, hey, I do need to step in here, but allowing that opportunity to take things on firsthand. After being diagnosed and had a lot of challenges with my feet, pressure sores multiple times a year with losing sensation and still just wanting to be a boy and try and run around and do all these things. And so that intervention was needed for me to say like, hey, you got to sit down, you got to stay off your feet. We need to take care of these wounds. And that was difficult. It was tough to give up that independence and feeling held back, but it's something that had to happen. And so I think, again, just being observant and knowing that independence is always the goal for a mom or dad as their child is getting older, but being able to provide support or intervening if necessary to make sure that they're in a good space, both physically and mentally.
That you had mentioned pressure sores. I know that can be one of those challenges, those medical challenges, and I know just from our previous conversations that you have had ostomies, have an ostomy. What medical challenges were really especially challenging for your routine? Was there anything that stands out to you, or just something you could share?
Yeah, I mean, developing before having the cecostomy, I went from being essentially from having access to being chronically constipated. And so I had to develop a bowel routine to manage that. And then the cecostomy was the hope that would overcome that challenge, which inevitably after multiple years of doing that, I realized that I was actually going to be more independent and better off having an ostomy. But bowel routines are really, I think, important. I have a number of friends who have had spinal cord injury, and if you ask them, if you ask someone who'd had a spinal cord injury, what would you like back? I think a lot of people think they would say their ability to walk, but really bowel and bladder function are so critical to someone's success. And so identifying a good routine to catheterize, if there's no sensation, ensuring that you have a way to monitor that so that they're not having backup into their kidneys, which can cause other challenges, and then managing a good bowel routine to prevent accidents, which in turn can help prevent skin breakdown, which then can help prevent pressure sores. So really that bowel bladder routine, I think, is something that mom and dad can start to talk with their little one about. And as we get older, we go through puberty, we become more private. If we can really set the foundation early on as to why it's so important, then there's a better chance of success to avoid other challenges a little later in life.
I really think that's great, and it's a great way to look at it, especially whenever you're teaching children. Having worked with pediatric patients for such a long time, that was always kind of my rule of thumb. Let's see what we can do, and then let's build from there.
Yeah.
And I agree, a strong foundation, making sure that we've got some of those basic things in check can really help for those more advanced things as they grow. And I think if you have that trusting relationship, I absolutely agree. It's going to allow for that vulnerability as kids get older and they really don't want to talk about those things.
Absolutely. And giving them a safe space where you can listen and you can ask them about their goals and what they want to do in terms of defining what independence looks like, working to teach skills and show, how they can manage their own care whenever possible, really leads to building confidence. And when you celebrate small successes, just like fitness, for example, you don't wake up one day and you're in great shape. You need to build on those small foundations of success that in turn kind of build the house that confidence built and allow them to get out and really thrive in the world.
Yeah, that's really a great way to look at it. How would you encourage caregivers to adapt environments based on their patients or their loved ones' needs?
I think advocating for access is always important. Understanding where someone's skill sets and abilities lie, and respecting autonomy and letting them kind of lead the way in the decisions of where they do need help or support. Someone may think, I don't have an accessible house, maybe we can't have them over, but someone may be very comfortable getting out of their wheelchair, for example, and just, as we call it, bumming up the stairs to get to that next level. And so never making assumptions that maybe that just because a space is not as accessible as maybe it could be, that individual or person doesn't want to have that experience and get out and enjoy an opportunity out in the world. So just asking those good questions and ensuring that you're listening to what that person is saying. And quite frankly, it may fail, and I think that's okay. Failing is okay, and it's something you can learn from. I think failure is when you refuse to take experience from something you went through. And so, it's okay for something to go wrong. It shows you how to maybe approach it a different way if you want really to accomplish something. And so having, again, those discussions as a family saying, hey, we're going to try this. It may or may not work. If it doesn't work the first time, we can assess if we want to take a different approach to it and whether or not that's an important thing that you want to accomplish.
Thank you. I really feel like that is a perfect spot to end this interview, but I really appreciate everything you said. Is there anything you want to add before we go ahead and close out?
I think a big piece for me was becoming comfortable with transparency and sharing my own experience with others so that they have a better understanding of who I am and what's taken place. It took me a number of years to get comfortable wearing shorts. I am ambulatory. I do walk with a limp. With that said, I wasn't comfortable wearing shorts, and it's something I've gotten over. The other piece too, though, is if you have a child who maybe isn't comfortable having their AFOs or their braces showing, help them feel comfortable at least at home, for example, starting that out. And then, in high school, I remember a friend's mom, unfortunately, dug through the garbage and thought that we were doing something nefarious because there was these plastic tubes in the garbage, and I had to explain, no, this is a catheter. And so for some of those younger kids, helping their parents understand if they are visiting friends or family who are close to them, for example, have a conversation about leaving some supplies at the house. If they do need a brief or they use catheters, have some extra product at that close friend or family's house. That way, if they do go for a sleepover, they're over for dinner and they forget their backpack, it doesn't put everybody into a tizzy. And it also sets mom and dad up for success, that they're not now suddenly jumping in the car and trying to rush off somewhere. It helps, again, just bolster that independence.
That's great advice. Thank you for sharing that. And I appreciate you being here and helping us to raise awareness and to educate those that are interested in learning more about spina bifida.
Yeah, thank you so much for the opportunity today. Thanks, Ferne.
So in conclusion, he was such an amazing person. I enjoyed so much getting to know him and talking with him, and I just thought he had such an amazing outlook on everything. But when he talked about the caregiver and he talks about how we make a plan, try to structure all of the things that you do that can make life easier. So if it's skin assessments, if it's making sure that there are certain things that you need to have at home, if there are certain things that you need to have with you, try to make that structured. As caregivers, it can be really, really hard to put ourselves first because we really want to take care of that person that we love or take care of that patient. And it's really, really important to remember that we got to take care of ourselves too, because like this quote says, and I'm sorry, I found it on the internet. I thought it was really beautiful, that behind every person with spina bifida is a caregiver building bridges over obstacles. And to me, that's what I'm here for. That's what we're here for as caregivers, is to make sure that we are building those bridges, that we are making it easier for anyone to succeed, whether they have a disability or have spina bifida or have anything that maybe we can't see, but making sure that we're always bridging building those bridges. And the daisy is the flower, the symbol for spina bifida. So I wanted to share this picture that I took. I think it's just such a happy way to close out. So I'm going to leave this up for just a few minutes. This QR code is for my benefit. If you could it's a very short survey. It'll take you less than 2 seconds, but please feel free to ask any questions that you have, and then I will stop sharing my screen.